1 second, ma'am.
Just tell you the exact slide number.
Yeah, 56 were where the diet starts actually.
Is the PPT visible?
Yeah,
Yeah, it's
PPT
visible.
is visible, but not the slide. Yeah.
Wait.
Yeah.
Not my name.
Maybe, yeah, from here.
Okay.
Little 2 slides before. One more. Yeah, we'll start from here. Shall we start?
Yes, sir. Good afternoon, everyone. We will start our session, please.
Can we have the next slide? Good afternoon, everyone. We'll just have a brief discussion on carbohydrate counting. So this is a healthy eating plate where the different portion sizes have been depicted. So when you discuss the diet pattern with any of your patients, when you want to give a diet counseling, you should advise them. Let us say half of the plate should be filled up with vegetables, the starchy as well as non-starchy, and whole grains kind of fill up by 1/4, fruits by 1/4, and remaining you can fill up with the healthy protein. So this again varies from region to region and varies from culture to culture. Can we have the next slide? I think many of you know the signal system, like the way we have the traffic signals, we have the signal system for foods as well. Red foods, the foods which have been given the red color signal should be avoided whenever and wherever possible, or once in a while can be taken in small quantities. And the yellow food should be taken in moderate quantities. Green foods are the healthier choices. They should fill up your plate. Next slide. So these are the various foods which represent the various colors. For example, if you take rice, steamed rice belongs to the green zone, pulao belongs to the yellow zone, fried rice or biryani red zone. The same way, if you have bread, all wheat bread is green zone. The same way, the remaining things as well. So what happens initially when you want to control the diabetes, when you want to bring down the sugars with the help of diet and medications, the diet pattern should be very much strict. And once the sugars are settling, once the HbA1c is less than 7, you can advise one cheat day per week. So cheat day in the sense, on that day, they can indulge in the food materials that are present in the red zone. So you can practice this. You can have a poster with you, pasted somewhere on the wall, so that patient can also look at this poster, and you can tell the patients regarding the various food materials that belong to various colors. Next slide. So basically coming to the diabetes management with the help of diet, as all of you know, there are 3 important body fuels. One is carbohydrate, second thing is a fat, third thing is the protein. Approximately 40 to 65% of our daily caloric intake should come from the carbohydrate, 20 to 35% from the fat, another 10 to 35% from the protein. In the same way, if you want to divide the food into diet into various food types, we have various food lists in practice. Like we have the starch list, we have the fruit list, we have the milk list, we have the this one fat list, and we have starch, fruit, milk, fat, and vegetable list. So these are the various lists which we have. So ideally speaking, none of the food material which we have does not contain a single type of food material. Example, if you take a starch food material like a rice or bread, it has all the 3 different types of fuels, maybe in different proportions. Few food materials will be having carbohydrate in a larger proportion. Few food materials will be having fat in a larger proportion. Few food materials may be having protein in a larger proportion. So this you should understand, and the patient should also understand this. So if you're eating a particular type of food material, doesn't mean you're not eating fat and protein. There might be a small quantity of fat and protein as well. Then second thing that you need to remember is counting of the food. So we have various calculators, various scales to count the food materials, but in the Indian setup, many of the patients may or may not be literate enough to count the particular food material. So these are the various methods to calculate and count the serving. So what do you mean by serving? Every serving has a particular grams of carbohydrate, and 1 gram of carbohydrate gives you 4 kilocalories of energy. So first thing you should remember, number of servings. Second thing, per serving, what is the total gram of carbohydrate? And you calculate the total grams of carbohydrate. For example, if you take one serving of bread, let us think like that. So one serving of bread might be equal to 3 slices of bread. And let us say one slice of bread is having 15 grams of carbohydrate. So if the patient wants to have 3 servings of bread, that is equal to 9 slices of bread, that is equal to 9 into 15 grams of carbohydrate. That's how we calculate. So that's how you get the calorie count as well. Here you can see, first you have the depiction of the punch. So one pasta is equal to one clenched fist or punch. The same way you have the hand and the palm, the central portion of the hand, that is equal to 3 ounces of meat or roughly 1/3 cup of rice. The same way you have the index finger, the tip of the index finger, that is equal to 1 tablespoon. The same way you have the thumb. The thumb might be equal to 1 more tablespoon in the form of, and then we have the clenched fist. For example, in the evening, we ask each and every patient to have 1 fist of nuts. Let it be cashew nut, let it be almond, let it be pista. So these are the various rough calculations which we have, which can be used daily in our life. Apart from that, we can calculate the food material in ounces, in grams. 1 ounce is approximately equal to 28 grams. So like that. Then we have various scales in practice. But many of the patients are not comfortable using this. So we can show them the handheld method, and we can show them various portion sizes with the help of cups. So this cup is equal to, let us say, 15 grams of rice, or this cup is equal to 45 grams of rice, or this cup is equal to 1 ounce of meat, like that. Next slide. So why is this carbohydrate counting very, very important for us, especially in type 1 diabetes mellitus? As there is no endogenous insulin, they're completely dependent on the insulin that they take from outside. So ideally, when you calculate the carbohydrate and when you calculate the number of kilocalories generated by that particular carbohydrate, then you can give a particular insulin to the patient. So it is very, very important, especially in type 1 patients, to calculate the total carbohydrate intake per day, and accordingly you have to give the insulin. We have various formulae like the insulin carbohydrate ratio, insulin sensitivity ratio, which you can practice. But basically you need to understand how to calculate the carbohydrate. So we have various things like sizes, portions, and apart from that we have even exchange. So basically we have various food labels which can be used in practice, like the way I told you, 1 slice of bread is equal to 15 grams of carbohydrate. The same way, let us say 1 apple might be equal to 15 grams of carbohydrate. 1/3 cup of rice might be equal to 15 grams of carbohydrate. Like that, you have various charts that can be used while calculating the carbohydrate. And you should teach the same to the patient. Let's say in the morning when the patient wants to have a food material, you can have various combinations of various things, and you divide the total caloric intake. Let us say 1200 kilocalories is the total caloric requirement per day, of which 65% or 50% should come from carbohydrate, that is equal to 600 kilocalories. And you can divide the 600 kilocalories into 3 major meals: one meal, one breakfast, one lunch, and one dinner. And how to calculate 600 kilocalories for the breakfast? We can use these various counting methods, either the Finch method or the fist method or the fist method or the punch method or the arm method, or you can use the portion sizes or the cup sizes, all these things. So this is how you calculate the carbohydrate. Second important principle is food exchange. The patient, you can't expect the patient to have 1 slice of bread every day. Today they had a slice of bread that is equal to 15 grams of carbohydrate. You can't keep on asking them to eat the slice of bread. Tomorrow they want to eat maybe apple. Day after tomorrow they want to eat some cereal. So let us say you told the patient you should be eating 45 grams of carbohydrate in the morning. What might be the type of carbohydrate. So today he might be having 3 slices of bread, that is equal to 45 grams of carbohydrate. Similarly, we have a list called food exchange list, where similar grams of carbohydrate from various food materials is depicted. Like 15 grams of carbohydrate should be given to the patient. So the 15 grams can be generated either from a slice of bread, either from a small sized apple, either from 1/3 cup of pasta. I'm just giving an example, either a 1/3 cup of noodles. So they can exchange these food materials. Today I had bread. Okay, tomorrow what is the equivalent to bread? You can have 1/3 cup of pasta. Okay, day after tomorrow, what can I have? You can have 1/3 cup of noodles. So that's what is food exchange. Food exchange is basically done with the similar type of food, like similar type of carbohydrate. You cannot interchange or you cannot exchange carbohydrate with fat or fat with protein. You can again interchange between 2 different fats or 2 different proteins. That's what this food exchange. So basically, you should teach each and every person having type 1 diabetes, and in fact, many of the type 2 diabetes patients as well, to count the number of carbohydrates using various methods like the palm method or the portion size or whatever might be. Second thing, they can even start practicing the food exchange principle. Can we have the next slide? So this is the exchange list. Roughly, you can see cereal 30 grams has 100 kilocalories of energy, 21 grams of carbohydrate, 22.5 grams of protein, 0.5 grams of fat, and 0.6 grams of fiber. Again, carbohydrate, you should remember, it can come from starch, it can come from sugar, it can come from fiber, it can come from non-starchy thing, it can even come from milk. That's how you should again understand. In the same way, you can exchange 1 cup of cereal with 1 cup of pulse, because both generate the same amount of kilocalories. Or if you want to take the same amount of carbohydrate, you should match them as well. Can we have the next slide? Yeah, the same way you can exchange the fruits as well. Can we have the next slide? Okay, can you depict that PDF which I have mailed you? Can you display that?
So, sir, I will just stop sharing the PPT.
Yes,
Then.
yes.
It's showing.
Yeah, it is visible. I think it's visible to each and everyone. This is an example of how you can understand the carbohydrate counting as well as the exchange. This is a sample meal plan for 1200 kilocalories. In this, the carbohydrate goal is 45 grams of carbohydrate per meal. And each serving or each snack is equal to up to 15 grams of carbohydrate. Initially, I told you there are different types of food lists. There can be starch list, there can be fruit list, there can be milk list, there can be meat list, there can be a fat list. So these lists can be used in each and different type of meal. Like in the breakfast, you can have a starch, you can have fruit, you can have milk, you can have vegetable, you can have fat, and you can even have the meat. In the same way with lunch, in the same way with the dinner. For example, in this particular thing, you can see breakfast, we have given 1 small banana, 3/4 cup of cornflakes, and 1 cup of fat-free milk. So 1 small banana belongs to the fruit list. 3/4 cups of cornflakes, that belongs to the starch, and 1 cup of fat-free milk belongs to the milk list. Now we tried to cover the maximum list in this particular meal. Second, what about the grams of carbohydrate? 3/4 cup of cornflakes, let us say, has 15 grams of carbohydrate. 1 small banana has 15 grams of carbohydrate. 1 cup of fat-free milk has 15 grams of carbohydrate. So we had 3 different food lists and 3 different types of food lists giving each 15 grams of carbohydrate. And the total carbohydrate intake is 45 grams. I think you understood this. Second, let us go to the lunch. In lunch, we have sandwich, 1 cup of raw carrot and celery sticks, and 1 small apple. Again, you have a fruit here with lunch, that is 1 small apple, and you have a sandwich which has all wheat bread, It has chicken breast 2 ounces. It has 2 tablespoons of avocado. Apart from that, you have 1 cup of raw carrot and celery sticks. So raw carrot and celery sticks can be given as a non-starchy vegetable. So you can see the bottom of this particular PDF. I don't know why is it not visible. Bottom of the PDF. Yes, thank you. Yeah, it is visible now. Here you can see for fruit, for the milk, and for the starch, 1 carbohydrate exchange is equal to 15 grams of carbohydrate. Let us say 1 small banana, 1 slice of whole wheat bread, or 3/4 cup of a cornflakes is equal to 15 grams of carbohydrate. For a non-starchy vegetable like a raw carrot and celery stick, it is equal to 5 grams of carbohydrate. So in the lunch, you have 2 slices of whole wheat bread, and you have 1 small apple that is equal to 15 grams, and you have 1 cup of raw carrot and celery sticks that is equal to 5 grams. So 15 plus 5, 20, and 2 slices of whole bread along with chicken breast and tablespoon of avocado gives you 30. So total 50 grams. If you go for the snack, you have 6 ounces of non-fat fruited yogurt with a sweetener. That is again given 1. The serving size is equal to 1 carbohydrate exchange, again giving 15 grams. And with the dinner, you have 2 ounces of a rib and you have half large baked potato, 1.5 tablespoon of reduced fat sour cream, half a cup of cooked beans with 1 tablespoon of olive oil, 3 almonds, and 1 cup of melon balls. 1 cup of melon balls, maybe you can add it as a fruit serving. Can you go up on the pan up a little bit? Yes, that's enough. So you can have 1 fruit list there. You have a fruit list, you have 2 starch list, and you have 1 non-starch list counting to 50 grams. So you can see we have given approximately 160 grams of carbohydrate per day. And if you calculate into 4, it comes to roughly approximately 740 kilocalories. So of the 1200 kilocalories meal plan, we have given 740 kilocalories, approximately 60% or 65% from the carbohydrate. And what we did further, we have divided the carbohydrate into 4: 1 breakfast, 1 lunch, 1 dinner, 3 major meals, and 1 snack. And again, with each meal, we try to include the list of food materials. Let it be starch, fruit, milk, non-starch vegetable, or a fat or meat. And again, within each list, we try to give servings. So 1 serving of a carbohydrate exchange is equal to 15 grams. 1 serving of a non-starchy vegetable is equal to 5 grams. This is an example of how you can use the carbohydrate counting. You have counted 1 small banana, 3/4 cup of a cornflakes, or 1 spoon of avocado. Like that, you're trying to count the carbohydrate. Second thing, you're trying to use the exchange as well. So here, for example, if you go for the breakfast, again, all the 3 are similar. Let it be 1 small banana, let it be 3/4 cup of a cornflakes, or let it be 1 cup of fat-free milk. All 3 are similar. So there you can implement the exchange model. I think it is a little confusing, but what I wanted to say is, if you want to give a particular meal plan to the patient, first calculate the kilocalorie intake depending on the target weight. The patient is overweight, you wanted to achieve weight control over 3 months. Accordingly, you calculate the kilocalorie intake. Then among that, you have to divide between carbohydrate, fat, and protein. Carbohydrate may be 40 to 65% per day. Among the carbohydrate, you should again come to the number of grams of carbohydrate that can be taken per day. And that again is divided into 3 major meals and snacks in between. And with each and every major meal, you can calculate the portion size and you can use the exchange principle so that the amount of carbohydrate taken remains stable. Are we clear? Any doubts here?
Sir, so the one ready to chart is available for knowing all these things.
Which one?
That the carbohydrate content of this particular
Yes.
size.
Yes. Any other doubts in this? If there are no doubts, we can proceed to the today's PPT. Or if there are doubts, we'll take
Girls,
a pause.
any questions?
So I have a question. See,
Tell me,
now
ma'am.
if I count the exchanges on the whole chart, it is 12, 1, 2, 3, 4, 5, 6, 7, 8,
3
9,
plus 2,
10,
5.
11. 12 exchanges?
Yes, 12 exchanges on
Okay.
the
On the whole, correct. So,
Mhm.
so when we say 1200 calories, we have to decide how many exchanges we are going to distribute for the whole day, isn't it?
Actually, what happens here, ma'am, the exchanges are not correlating to the number of kilocalories. Here, the exchanges are correlating to the number of grams.
Number of grams,
So,
correct.
yeah, simple principle, one exchange of a regular starch or regular carbohydrate is equal to 15 grams of carbohydrate.
Correct.
One exchange of a non-starchy thing is equal to 5 grams. So using this
Correct.
exchange principle, you're trying to calculate the number of grams of carbohydrate per day.
Per day, correct.
Mm.
Okay.
So what happens here? 1200 is the kilocaloric intake ideally per day, of which let us say you wanted to give some 60% from carbohydrate.
Okay.
Let us say 60 or 60% comes to approximately 740. Let us
Correct.
think like that.
Yeah,
Correct.
So that 740 kilocalories should be generated by number one, how many grams of carbohydrate divided by 4.
Correct.
Then you'll get the number of grams of carbohydrate that need to be taken per day. Let us say you got some 740 by 4, it comes to approximately some
185.
180 grams of carbohydrate. So
Correct.
this 180 grams of carbohydrate, using this particular exchange principle, you can divide it into breakfast, lunch, dinner, along with snacks.
Okay. Okay.
Let us say you have given some 60, 60, 60. I'm just telling you an example. 60
Correct.
grams for breakfast, 60 for lunch, 60 for dinner.
Correct.
And within that 60 grams of breakfast, ideally speaking, you go for a normal carbohydrate or normal starchy meal. Then you can
Correct.
give 4 exchanges. Each exchange is 15 grams.
Correct.
Then within that exchange, you can pick any food material according to your
Correct.
choice. It
Correct.
can be an apple, it can be banana, it can be cornflakes, it can be some slice of bread. All of these are equal to, one exchange is equal to 15 grams of carbohydrate. That's
Carbohydrate.
the
Correct.
principle. And
Sir,
within the exchange, yeah,
we also take our Indian foods like idli and things like that.
idli and things like that. There, this serving comes into play. Let us say one idli serving is equal to 2 idlis. And 2 idlis is equal to, let us say, 15 grams of carbohydrate. So if you want to tell a patient, you cannot tell eat 15 grams of carbohydrate. They will never understand in their life. So
Yes.
what you can say is one
Two
small
idlis.
medium size idli, each idli, I mean, one serving is equal to 2 idlis. And 2 idlis will give 15 grams. So you can have one serving in the morning, like that example you can say. So the patient understand, okay, what about coconut chutney? If you want to add coconut, you ideally should not have coconut chutney, but if you want to have coconut chutney, one serving of coconut chutney is equal to 3 tablespoons. So 3 tablespoons of chutney is again equal to 15 grams. So morning you are having 30 grams of carbohydrate from 2 idli and 3 tablespoons of chutney. Like that. Okay, this is my intake. That's how they understand.
Okay.
And there is a doubt in the chat box as well. Sir, could you please repeat the exchange of carbohydrates and hand rule? Hand rule is very simple. See, for example, if you want to have, you just want to have pasta in the morning. And we told the patient that 3/4 cup of pasta is equal to 15 grams of carbohydrate. Then the patient will not understand. See, in my house, the cup size will be this much. In the neighboring house, the cup size will be this much. And in the third house, the cup size will be this much. So we cannot ideally say we don't have a metric like tablespoon for the cup. Tablespoon, we have a metric everywhere. Let it be India, let it be anywhere. Like 1 tablespoon is equal to 5 ml, 10 ml, 15 ml, like that. So to understand this particular principle, you can say if you close the fist and if you look at the punch, that is equal to 3/4 of a pasta. If you open your hand and the middle portion of the palm, that might be equal to 1 serving of your rice. If you want to say 1 tablespoon of olive oil, the index finger will be equal to 1 tablespoon of olive oil. And if you want to say you should have nuts, 1 fist of nuts, that is equal to 1 serving. So for a layman who may not be knowing about these metrics, you can teach them this hand principle. And nowadays, many of the registered nutritionists are having the portion cups with them. So they can show the portion cups to the patient. You can have this much of rice, you can have this much of pulao, you can have this much of dal, that is equal to 15 grams or 30 grams or 45 grams. Like that, you can show the patient these portions. Any other doubts?
So
are we
once
clear?
they do it, they will understand, sir. When we go
Once
back
they
to
do it, yeah.
yeah,
Yes, yes.
we will go back to college and give them the book where
Yes.
all the lists are given, so that when they see it,
Yes.
they will be able to do it.
Yes. 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 I think this is a little clear for all of them.
Yeah, this
Hope.
is clear.
This
Yeah.
is very clear.
Yeah. Yes. So shall we go to the today's discussion?
Yes, sir.
Okay, so sir,
About GI, sir.
glycemic
GI actually more than GI, they should learn about the glycemic
Load.
load more than the
load.
index. Yeah, the principle is that is the reason we did not. Now many of these lectures are they are not including GI for the time being because they wanted to include the glycemic load rather than the glycemic index. GI is becoming an outdated concept nowadays. They have identified because let us say if you tell the patient, if you tell the person that apple has less glycemic index than mango, let us think like that, and the patient wants to have one small size apple which might be equal to 15 grams of carbohydrate, but the patient can ask me, I want to have one slice of mango as well. Can I exchange one slice of mango with one slice of apple? So rather than telling the patient regarding the glycemic index is nothing but the amount of sugar that goes up after eating a particular grams of carbohydrate, that is index. But we are more worried about the load, that is we have to include the servings and the portion sizes as well, and the quality of the carbohydrate as well. So glycemic load again is a fast catching up principle. We're trying to include glycemic load rather than including glycemic index. Anyway, you can go back to the, did we have anything on the glycemic index or load in the slides?
No, no.
Yes, that is the reason we have it included. Other than that, so maybe if you want me to discuss about that, we can discuss, or else we can have a discussion on the glycemic load alone.
Sir, you can just explain the glycemic load then.
Or
Just
else let us first finish off this particular the today's
Yes.
thing,
yes,
and at the end of that I will just explain to them regarding the index and load.
yes. So, shall I
Today's-
project case PPT?
Yeah. Yes, you can project today's PPT.
So if you have a list of all the glycemic index and load of Indian foods, can you share it with us?
Yeah, sure. I will do that. I'll send a mail to them regarding the glycemic index and load of all the Indian food materials.
Okay. Thank you.
Mary ma'am, what about the? We were having that Mohan's atlas, no? Is it
Atlas. Yeah, that also
that also the portion sizes actually they have given with the pictures, no? Vali ma'am, you remember this?
Mohan's Diabetes Atlas, no?
Atlas, yeah. So I think that also will help the children.
Correct.
Ma'am, PPT.
Well, you have gone through that, no, doctor?
Yeah. That is also quite useful. That actually they have taken into consideration the various regions of India and various types of food materials. For example, mango itself, you can see in that particular atlas, will have different types of mangoes and different types of carbohydrate according to the mango size.
Is the PPT came?
Yeah.
Okay.
You have to put it slideshow. That's it.
Yeah.
So we'll have a discussion on the complications of diabetes. And lastly, we're going to touch upon COVID-19 diabetes. Can we have the next slide? Basically, complications of diabetes are of two types: acute or short-term complications, chronic or long-term complications. Acute complications, if you see them immediately within few days to few weeks, are acute. And chronic, if you start seeing them after 6 weeks to 6 months, is chronic. Basically, less than 6 weeks is acute, more than 6 months is chronic. Anything between 6 weeks to 6 months is called subacute. Next slide. So acute complications, basically we have three different types of acute complications. One is hypoglycemia, second one is diabetic ketoacidosis, third one is hyperosmolar hyperglycemic state, that is HHS. So you can roughly remember, one complications because of low sugar, two complications are because of high sugar. So let us discuss about hypoglycemia first. Next slide. What do you mean by hypoglycemia? According to the textbook definition or the definition given by the American Diabetes Association, any blood glucose value of less than or equal to 70 milligrams per deciliter is called hypoglycemia. So when you start treating a person having diabetes, that too, when you start giving an intense therapy, you have to expect hypoglycemia at one or the other point of time, especially when the patient is on insulin. And especially in type 1 patients, hypoglycemia is a fact of life. They can never escape from hypoglycemia. So when the patient comes to you, when you start the treatment, you should tell them invariably you're going to have hypoglycemia. It is a fact of life. But the thing with hypoglycemia, if you're able to prevent hypoglycemia, further hypoglycemias can be prevented. In what way? The problem with hypoglycemia, let us say today the patient's sugar is 300. You have started him on insulin or her on insulin, all the tablets, and maybe after a week, suddenly the sugar dropped to 54. Initially, the patient will have some symptoms of hypoglycemia like neurogenic and adrenergic. Neurogenic in the sense the brain will send some signals. The patient will have some hunger, some confusion, some lethargy. All these are from the brain. The same way, the sympathetic nervous system is also getting activated. The patient will have sweating, palpitations, tremor, and all these things. So these are the classical symptoms of hypoglycemia. Patient neglects, he will not do anything for this hypoglycemia. Then the brain brings down the threshold for low glucose from 70 to 50. Okay, let us say at 65, the patient will not have any symptom because the threshold has been brought down to 50. One fine day, the patient's blood sugar drops further to 45. The brain will check, okay, is he doing something? No, he's not doing anything. Okay, let us have the symptoms. In spite of having symptoms, a particular person is not doing anything. Okay, the brain will wait for 2 to 3 cycles. At the end of the third cycle, the brain will understand, in spite of having a blood sugar of 45, this particular gentleman is not doing anything. It will further bring down the threshold to 40. What happens when the sugars are dropping to 40? You will start having cognitive impairment. The brain will not get a proper blood glucose supply. You can start having memory loss. You can start having seizures, fits, which is quite detrimental. So, whenever a particular person is having hypoglycemia, it is always better to prevent further attacks of hypoglycemia so that the threshold for hypoglycemia is not brought down. Okay. Second, so we understood these are the symptoms of hypoglycemia. We understood that any person taking treatment for diabetes, let it be with oral drugs like sulfonylureas, let it be with injectables like insulin, is prone to develop hypoglycemia. How to prevent hypoglycemia? First thing, they should always eat on time and they should have snacks in between, a mid-morning snack, a mid-evening snack, and a bedtime snack so that they may not develop hypoglycemia. Second thing, they should develop the habit of anticipation. Today, the patient came to you, you started him on insulin, they went back, sugars have come down, fasting came down from 240 to 120, we're happy. After the meal came down from 300 to 160, we're all happy. Everything sounds good. After the COVID-19 has settled, this particular person who is staying in home started going to work. Then initially he was in home, he's not doing much work. When he starts going to his office, he will be walking a lot, he will be climbing the stairs up, he will be climbing down the stairs. So he will start spending more and more energy. So with the same meal, with the same dose of insulin, the patient will start having hypoglycemia. That's when the anticipation plays a role. The patient has to anticipate, okay, today my workload is going up, I might start developing low sugar. So instead of taking 12 units of insulin in the morning, let me cut down the insulin to 10 units. The other extreme, daily is having insulin, sugars are under control, everything is fine. One day he went to a marriage function where he had chicken biryani. There, the sugars will shoot up. So he should anticipate that and he has to increase the dose of insulin from 12 to 14. So these things the patients will learn with experience and you should also tell them. The next thing is, what is the treatment for hypoglycemia? Whenever the patient is having a symptom of low sugar, first thing, they should check the sugar. And if it is less than 70, there is only one treatment for low sugar in the world, that is glucose. Either the patient can have 2 tablespoons of glucose, that is roughly equal to 15 grams of glucose in a glass of water, or else they can chew a glucose tablet. And they have to recheck the sugar after 15 minutes. If it is increasing by 15, let us say it was 65, it went to 80, we're happy. If it is not increasing, or if it's still less than 70, they need to repeat this step. And immediately, the moment they take glucose, after that, they can have chocolate, biscuit, candy, fruit, whatever they want. But initially, if they have chocolate, biscuit, candy without having glucose, this particular chocolate, biscuit, or candy will take minimum 30 minutes to increase the blood glucose by 15 units. So the patient will continue to have hypoglycemia symptoms. They will start eating a lot. Instead of having one idli, they will have two idlis, three idlis, four idlis. After 30 minutes, the sugar will become 300 from 65. So always you should advise the patient, initially you should have glucose followed by whatever you want. This is if it is happening between breakfast, lunch, between lunch and dinner, or sometime early in the morning around 3 a.m. or 2 a.m. What if the hypoglycemia is happening just before a major meal like lunch? 1 o'clock is the lunchtime, 12:30 the patient had hypoglycemia. Initially, they should have the glucose followed by an immediate meal. That's how the things work. And one more important factor which we should always remember apart from all these things is, especially in type 1 patients, suddenly the fasting sugar will go up. Till yesterday, the fasting was normal. Yesterday, fasting was 120. Day before yesterday, it was 90. Today, the fasting will become 400. So they should not panic and they should not unnecessarily increase the dose of insulin. When there is a hypoglycemia at around 3 a.m. in the night, many of them will not have symptoms, or they might be having one bad dream. So when there is a hypoglycemia at around 3 a.m. in the morning, the fasting will go up. It is called somogai, SOMOGYI. What is somogai? The body tries to pump in glucagon so that the sugar levels will go up. So body will not have a particular meter to say, okay, the sugar is at 40, I should pump this much glucagon. It keeps on pumping glucagon until unless the sugar is corrected. Sometimes it will get overcorrected and the fasting appears to be high. The problem is nocturnal hypoglycemia, not the fasting hyperglycemia. Can we have the next slide? So these are the risk factors of hypoglycemia. If they did not take a proper food, if they have missed the meal, if there is a late meal, and there is excess of insulin or medication dose, prolonged physical activity, history of hypoglycemia, pregnancy, and all these things. And one more important thing is chronic liver disease and kidney disease. So what is happening? Insulin is cleaved by an enzyme insulinase in the body. So insulin is very short acting. When you take insulin from outside, or the endogenous insulin will not act for a prolonged time because there is an enzyme by name insulinase inside the body, which is produced by the kidney. In chronic kidney disease, the insulinase enzyme is not properly produced. So insulin will start acting for a prolonged period of time. So you should expect hypoglycemia in chronic kidney disease patients. To prevent hypoglycemia in them, you should make sure the targets are relaxed in them. And alcohol is one more substance which will cause hypoglycemia. So if you come across any alcoholic uncle, you should tell the uncle, please have something when you take alcohol, because you can develop hypoglycemia. Can we have the next slide? So this is how the body switches off glucagon and switches off insulin and switches on glucagon. In the first session, we had discussion regarding insulin and glucagon. Glucagon will make sure the liver is producing more and more glucose by hepatic gluconeogenesis and glycogenolysis so that sugar levels increase in the body. The same way, temporarily, I'm talking about type 2 diabetes mellitus, not type 1. In type 2 diabetes mellitus, temporarily insulin will be switched off. Next slide. So these are the various symptoms of hypoglycemia. You can have headache, you can have mood changes, you can have tremors, palpitations, and all those things. Night times, you will have a nightmare, you will not have any of these symptoms. And it is so dreadful, especially in elderly people. Hypoglycemia can precipitate a heart attack. It can precipitate a silent myocardial infarction. So hypoglycemia is very, very important. The patient should neither have a hyperglycemia nor a hypoglycemia. Next slide. So this is what hypoglycemia unawareness, that's what I told. The threshold for hypoglycemia will be brought down by the brain so that in spite of having a hypoglycemia, patient will not be having any symptom. So we should always try to prevent this hypoglycemia unawareness. And there is a syndrome called hypoglycemia associated autonomic failure that is a part of unawareness. Next slide. So these are the consequences of hypoglycemia, mild to moderate. You will have the patient will have fear. It's a very, very dreadful condition. They will stop taking insulin. They will stop taking the oral medications because of the fear of hypoglycemia. And in severe hypoglycemia, they can have injury, they can have seizures, they can have paralysis and all those things. Next slide. So management of hypoglycemia, this is called rule of 15. Take 15 grams of glucose, wait for 15 minutes, and after 15 minutes, you should recheck the blood glucose value. It should go up by 15. If it is not going up by 15, again repeat this step. Next slide. This is what I told you in the first discussion as well. Glucagon. Glucagon injections, even though they are not available in India, they were available in Europe and United States of America, where usually they are given for both adults as well as for children. Approximately, they will give 1 ml of glucagon injection for adults and 0.5 ml of glucagon for children. It increases the blood glucose by approximately 54 to 216 milligrams per deciliter in 60 minutes. Next slide. So this is how the ADA is even recommending. If you have any form of hypoglycemia, you should actually, whenever you see the patient, whenever the patient comes back to you for review, you should always ask the patient not only about the diabetes management, not only about diet, not only about lifestyle, you should even stress upon the hypoglycemia, whether they had hypoglycemia or not, whether that is a mild hypoglycemia. What do you mean by mild hypoglycemia? The value was around 70, the patient had symptoms. Whether it is moderate hypoglycemia, moderate in the sense less than 70, and it was around 60, 65. Severe hypoglycemia, what do you mean by severe hypoglycemia? Patient needed a third party assistance. The patient became unconscious. Someone had to give glucose to the patient. That is a severe hypoglycemia. You should even ask the patient when the hypoglycemia happened, whether it happened before a major meal, whether it happened in the morning, whether it happened in the night. All these things you should make a note of these points so that you can discuss with the patient what are the steps that needed to prevent hypoglycemia and what are the things that need to be done during the episode of hypoglycemia. Next slide. So this is how you can prevent hypoglycemia. Anticipation is very, very important. You should tell the patient, for example, a type 1 patient wants to do exercise in the evening at around 4 p.m. You should tell the patient before and after exercise, please take something. Have something before going for exercise and have something immediately after exercise so that you can prevent the hypoglycemia. And pregnancy is one more important thing when it comes to hypoglycemia. Ideally speaking, pregnant women can tolerate a value of up to 50, 55. There is nothing like a hard and fast rule that pregnant women are going to have hypoglycemia. Because in pregnancy, the blood pressure will come down, hemoglobin will come down, everything will come down, including your blood sugar. So that is the reason the targets for blood sugar are very, very, very tight and very, very low in pregnancy. Fasting is around 60 to 90, 1 hour after meal, not 2 hours after meal. 1 hour after meal is equal to 90 to 140. So even if a pregnant woman is having a 55 value on fasting, the woman need not worry and we should not worry. So in pregnancy, a value of even 50 is expected, which is not hypoglycemia, but we should not have too low values like 40 fasting or 60, 70 post meal, which is not good for the fetus. Even at a value of 40, the mother will not have any symptoms, but more and more hypoglycemia in pregnancy is not good for the growth rate of the baby. Next slide. So these are the special considerations, especially in older people more than the age of 70. If they have hypoglycemia, they can fall, they can injure themselves. And when a person is driving, you should tell them to be very much careful and you should not have develop hypoglycemia. One important factor which I want to mention is insulin intake. Many of them try to inject the insulin on the arm. Ideally, if you're self-injecting or self-administering the insulin, it should be taken on the abdomen or on the thighs, not on the arms. The problem with the arm, there are small, tiny, very, very tiny and numerous small blood vessels which are not visible to us. So by mistake, instead of the insulin becoming subcutaneous, it can become intravenous. So when the insulin subcutaneous, analogs will work in 10 to 30 minutes. The regular insulins will work in 30 minutes to 1 hour. But when the insulin becomes intravenous, it works so fast, within 5 to 10 minutes, the sugars will drop. Few patients, what they will think, okay, I'm just staying a kilometer away from my home. and let me start my vehicle. I will have the insulin. The moment I go home, I will have my lunch or dinner. But what if they have injected the insulin onto a vein? Within 5 minutes during driving itself, they will have hypoglycemia. So these are the practical considerations, practical points which you need to discuss with each and every person. Next slide. So the first major acute complication of diabetes being hypoglycemia, we have discussed regarding that. There are two major acute complications with regards to high blood sugar. One is diabetic ketoacidosis, the other one is hyperosmolar hyperglycemic state. Diabetic ketoacidosis, I will just not take much time. We'll keep it simple. What is basically happening? Let us take a type 1 patient into consideration. Type 1 diabetes, there is no insulin left in the body. So patient had 2 idli, sugars became 300. Even then the body is not able to utilize the sugar because there is no insulin to drive the sugar into the muscles or any other tissue of the body. The patient will start having hunger episodes because there is no energy. So again, he will have 2 more idli. The sugar will become 500. Even then, the sugar is not being pumped into the muscle. Again, he will have 2 more idlis. The sugars will become 500. So the sugars are going up to 500. Even then, patient will have a hunger episode because there is no energy. Brain will see, okay, enough with the idli part. Leave about idli. In spite of having idli, your sugars are going up, but there is no point in having idli. Let us stop with the carbohydrate. Search for the next fuel. Okay, the brain will say, liver, why don't you produce glucose on your own? So liver will start doing glycogenolysis, gluconeogenesis, all those things. The sugars will become 700. Even then, the patient is having hunger attack. Okay, now let us switch to the next fuel in the body. What is the next fuel in the body? Fat. Now the patient will start utilizing the fats. When the fats are being burnt, you will have more energy when compared to carbohydrate. Ideally, 1 gram of carbohydrate will give 4 kilocalories, whereas fat is giving 9. So the patient will feel energetic. Good. But what is happening here? The end product of fat metabolism is a ketone body. So the patient will start utilizing the fat from the adipose tissue, fat from the muscle. The patient is getting energy, but you're accumulating ketone bodies in your body. Ketone bodies are waste products. Our bodies will not utilize ketone bodies. Ideally, if the ketone bodies are produced in a very mild quantity, they are excreted by the kidney. But when you start repeatedly utilizing the fat, ketone bodies start building up in the body. And these ketone bodies are weak acids. So what is happening here? Because of the absence of insulin, blood sugar is going up to 700. Because of the presence of ketone bodies, you're developing acidosis. So there are three things here: diabetes, that is increased blood sugar; ketosis, that is ketone bodies; acidosis, that is acid. So it is a combination of all these three things put together. It is called diabetic ketoacidosis. What happens now? Body will not keep quiet. Okay, sugar has gone up to 700. There are ketone bodies inside the body. What the brain will say, the brain will tell the kidney to shunt out these particular glucose molecules or ketone molecules. So the kidney will start producing more and more urine. So through that urine, body will try to excrete the ketone bodies and excrete the sugar. So the patient will have polyuria. But with polyuria, the patient will have dehydration. So the patient will have hypotension. The patient can collapse. It is a very, very, very detrimental condition. If you don't treat it immediately, the acidosis and the ketosis is going to directly affect the heart and the brain. The hypotension and the dehydration is going to affect the heart. So if you don't treat diabetic ketoacidosis, the patient is going to die. 10 years, 15 years, 20 years back, many of the type 1 patients used to die because of diabetic ketoacidosis. But because of the recent advances in the treatment, more and more awareness, we are able to prevent the attacks of diabetic ketoacidosis. And whenever a patient is presenting with diabetic ketoacidosis, we're able to immediately take care of the patient. So what we usually do, an interesting point, type 1 patients, first time they will come to know that they have type 1 diabetes with an episode of decay. Suddenly the patient will be normal till yesterday. He will have some party with his friends. He will have some pizza, burger. He will develop gastroenteritis. He will develop loose stools and he will get admitted in a hospital. When they check the sugar, it will be 700. That is an attack of diabetic ketoacidosis. So what you usually do for diabetic ketoacidosis, first you should correct the dehydration. You should pump IV fluids. Second, you should correct the acidosis. Third, you should correct the hyperglycemia with the administration of insulin. This is what, in a nutshell, is diabetic ketoacidosis. Can we have the next slide? So this is what is happening. Insulin deficiency will increase the lipolysis, and increased lipolysis will cause ketogenesis, ketonemia, and ketonuria, which can cause dehydration and acidosis. And decreased glucose uptake because of insulin deficiency can cause hyperglycemia, can cause glucosuria, can cause water loss. Next slide. So these are the various factors, precipitating factors for diabetic ketoacidosis. It can happen because of infection. It is most commonly seen in type 1 diabetes mellitus, but it can even be seen in type 2 diabetes mellitus. It can be presenting with some episodes of pancreatitis, myocardial infarction. Sometimes elderly people with type 2 diabetes mellitus, if they develop heart attack, and when you rush them to the hospital, during that period of time, they can develop diabetic ketoacidosis. And some medications like corticosteroids also can cause diabetic ketoacidosis. Next slide. So these are the various signs and symptoms of diabetic ketoacidosis. They can have polyuria, polyphasia, and polydipsia. They can have tiredness, muscle cramps, and all those things. Next slide. Yes, these are the late clinical signs and symptoms of diabetic ketoacidosis. They can even have vomiting, nausea, abdominal pain, dehydration, all those things. Next slide. So blood glucose levels are usually elevated. You can have urine ketone bodies as well as blood ketone bodies. If you check the electrolytes, you can have low sodium, you can have low potassium, you can have low bicarbonate. And if you check for the pH, pH can also be low. Next slide. So this is how you manage. First thing, you should always correct the dehydration with the help of IV fluids. Then you should take care of the electrolytes and acidosis. Then you should take care of the blood glucose with the help of insulin administration. Next slide. So what is hyperosmolar hyperglycemic state? It is almost similar to diabetic ketoacidosis. The difference being diabetic ketoacidosis predominantly is present in type 1 patients. It can be seen in type 2 as well, but hyperosmolar hyperglycemic state is present in type 2. The difference being in type 2, we don't have absolute insulin deficiency like type 1. There is some insulin left inside the body, which is not working. So this insulin is actually protecting the sugar from going beyond 700 or 800. This insulin is the one which is going to protect us from developing ketone bodies and acidosis. Even though HHS looks like DKA, the difference between HHS and DKA is that HHS, the sugars can be as high as DKA, but you will not have ketone bodies like DKA, and you will not have acidosis like DKA because there is some residual insulin left in the body. But the difference is in HHS, the osmolality will go up, not like DKA. So it is usually seen in type 2 diabetes mellitus patients, especially elderly people who develop heart attack, who develop stroke, who develop pneumonia. They can even develop this particular condition. The treatment almost remains the same. Dehydration can be corrected with rehydration, insulin administration, and treatment of electrolyte disturbance in acidosis. Next slide. Next slide. Next slide. So both are almost similar. That is the reason I'm skipping these slides. Next slide. Next slide. Next slide. You can go to the complications, the chronic complications of diabetes. So you keep on skipping the slide. So we have covered the acute complications of diabetes. Let it be hypoglycemia, let it be diabetic ketoacidosis, let it be HHS, hyperosmolar hyperglycemic state. One important principle which you should always remember is sick day rule. What do you mean by sick day rule? You can skip, you can go to the chronic complications. Sick day rule is that, yeah, you can stop here. So whenever you see a patient, let us say type 1 diabetes mellitus patient, suddenly the patient develops loose stools and vomitings, fever, abdominal pain. The patient doesn't want to have any food material. So mother calls you up. Patient is having type 1 diabetes. He's supposed to take insulin shot with lunch, but he's having vomiting since morning. He doesn't want to have any food. Can I give the insulin or not? You should always tell that particular parent or particular patient that they should never stop the basal insulin. During the insulin class, if you remember, we have discussed basically there are short acting and long acting insulins. And in the insulin regimen, we have a basal bolus insulin regimen, which closely resembles the physiological profile of the insulin. That is, we are going to give 3 shots of insulin before the meal, before the breakfast, lunch, and dinner, and 1 shot of insulin bedtime. So that bedtime insulin should never be stopped in a type 1 diabetes mellitus patient. That is the one which is going to prevent the diabetic ketoacidosis. Maybe instead of taking the complete 100% insulin dose, they can take some 60 to 80% dose. What about the bolus short acting? You can stop the bolus provided you are checking the sugar once in 2 to 3 hours. If the sugars are well below 200, no need to take the bolus because the patient is not having any food. But if it is more than 200, we should take a short dose, maybe 2 units or 4 units of the short acting to prevent further high sugars. This is what is sick day rule. The same thing applies to many Indian housewives who do fasting. What they think, today I'm supposed to take metformin in the morning, metformin in the night, and I'm going to let us say some Karwa Chauth or some Varalakshmi Vratam. Today I don't want to have any food. I should not take metformin ideally, but if you check their sugar in the evening, it will be some 300. Because when they don't take the drug, initially they might be having a low sugar. Body starts compensating for that by producing more and more glucagon, and their sugar levels will shoot up to 300. So whenever they're going for fasting, you should tell them to drink plenty of fluid. And second thing, they should check the sugar once in 2 hours to prevent conditions like hyperosmolar, hyperglycemic state in that. Can we have the next slide? Yeah, this slide only. Yeah, just go back to the previous slide. So we're done with the acute complications of diabetes. Coming to the chronic long-term complications of diabetes, there are 2 types, microvascular and macrovascular. Microvascular in the sense complications because of the small vessels. We have small vessels in the nerves, in the kidneys, in the eyes. And if these small vessels are affected, these vessels can either be damaged or these vessels can be blocked. If anything is happening to these small blood vessels, it is called a microvascular disease or a microvascular complication. If they're affecting the nerves, it is called neuropathy. If they're affecting the kidney, it is called nephropathy. If they're affecting the eyes, it is called retinopathy. And if the large blood vessels are affected, it is called macrovascular, like the blood vessels in the heart, cardiovascular, in the brain, cerebrovascular, in the lower limbs, peripheral vascular. So first, let us finish off the microvascular. Next slide. So microvascular, again, we have 3 types: retinopathy, eyes; neuropathy, nerves; nephropathy, kidneys. Retinopathy, very simple. What is happening? The way each and every organ in the body has blood supply, eye is also getting blood supply by a major blood vessel by name ophthalmic artery. You can see this particular picture. I don't know whether it is visible to you or not. The central part of the picture, you can see an yellow colored spot. From that spot, the ophthalmic artery is spanning out and it is getting divided into various blood vessels which supply the retina. In the eye, the way we have the regular camera, the not the camera in the present in the mobile. If you take the regular camera, you have a lens and you have a film. So the same way in the eye, you have a lens and a film. The lens is the one which is getting affected in cataract. The film is the one which is getting affected in retinopathy. So in retinopathy, because of the block in this particular blood vessel, you will start having the eye disease. So when you have uncontrolled diabetes, there can be a block in this blood vessel, which can lead to diabetic eye disease. Basically, what is happening? Blood vessel supplying to the eye, well and good. But when there is a block in this major blood vessel, eye starts producing small blood vessels, which start supplying to the eye. But these small blood vessels are not as strong as the original blood vessel. So these small blood vessels start breaking up, then blood starts oozing into the eye. So we have various stages of diabetic eye disease. Next slide. Next slide. So we have various types of retinopathy, like the non-proliferative, proliferative, or else you can divide them like mild non-proliferative diabetic retinopathy, moderate non-proliferative diabetic retinopathy, severe non-proliferative diabetic retinopathy, and we have very severe. And we have at the other end proliferative. What do you mean by non-proliferative and proliferative? In non-proliferative, even though there is a block in the blood vessel, you don't see any other new blood vessel. Only there can be hard exudates, there can be cotton wool spots and all those things. In proliferative diabetic retinopathy, you will see the formation of new blood vessels in the eye. And next slide. Next slide. So whether you have a proliferative retinopathy or a non-proliferative retinopathy, the central part of the eye is called macula. There can be a swelling at the level of macula, like the way you have a swelling of the ankle, like the way you have the swelling of the abdomen, it is called edema. That particular macula will also have edema, it is called macular edema. So macular edema can be present either with a non-proliferative diabetic retinopathy or a proliferative. To keep it simple, retinopathy is present because there is a block in the blood vessel. The block in the blood vessel can lead to the formation of new blood vessel. If there is formation of new blood vessel, it is called proliferative diabetic retinopathy. If there is no formation of new vessel, it is called non-proliferative diabetic retinopathy. So what are the take-home messages for you when it comes to retinopathy? Every person having diabetes mellitus should always undergo an eye examination when they visit you for the first time. It is mandatory. You will refer to the patient to an ophthalmologist. The ophthalmologist will examine the eye. They will dilate the pupils. They will see, they look at the retina. If there are no changes in the retina, we have to repeat the examination after 1 year. Let us say there are changes in the retina. Let us say the person is having mild non-proliferative diabetic retinopathy. Again, we have to repeat the test in 9 to 12 months. What if they're having moderate non-proliferative diabetic retinopathy? You have to repeat the test in 6 months. What if they have severe or very severe? You have to repeat it after 3 months. What if they have proliferative? Immediately you have to treat them. This is coming to the retinopathy. That particular macular edema, which I told, there can be swelling in the middle of the eye, can be present either with mild non-proliferative diabetic retinopathy. It can be present even with PDR, that is proliferative diabetic retinopathy. Even when they have a swelling in the eye, the ophthalmologist will treat the eye immediately. The problem with retinopathy is one of the most common complications of diabetes. It can result in blindness, permanent blindness, if you don't treat it properly. Why they develop retinopathy? Because of uncontrolled sugar. And if they have other comorbidities like uncontrolled hypertension, uncontrolled lipids, and if they start smoking, if they take alcohol, then you see more and more severe levels of retinopathy. This is for type 2. In type 1, what happens initially for 5 to 10 years, they have a buffer period where they don't develop retinopathy. But after the initial 5 to 10 years, you have to do regular assessment like a type 2. One more important group is pregnancy. Any pregnant woman with diabetes, she never had diabetes in her life. During pregnancy, she developed diabetes. It is always mandatory for her to undergo the eye test because retinopathy, if present during pregnancy, progresses very rapidly because pregnancy is a hypoxemic state. There is no oxygen supply during pregnancy. Oxygen levels will come down during pregnancy and the eye will be affected very, very badly. So these are the various aspects of retinopathy. Can we have the next slide? Next slide. We'll straight away go to the nephropathy. Next slide. Yes. So nephropathy, same like retinopathy. If the small blood vessels are affected in the kidney, it is called nephropathy. So nephropathy, so what are the symptoms of nephropathy? The patient will start having frothy urine. So what is happening in nephropathy? I don't know whether you might be aware of a thing called glomerulus. Glomerulus is like basically kidney is like a filter. It's like a sieve. It is trying to filter everything. It will even filter the protein. Proteins are basically large molecules. They will not easily pass through the kidney and enter the urine. But what is happening in diabetic nephropathy, when the small blood vessels are getting affected, this particular sieve, the size of the sieve is getting enlarged. Imagine the sieve and you imagine rice. If you add rice and if you subject it to filtration, either rice will stay back or the waste will stay back. In our native villages, they used to use a sieve to filter the rice so that all the stones will go out and rice will stay back. The same thing the kidney does. Kidney is trying to filter the protein so that the protein stays back and all the waste is going out through urine. But when you have uncontrolled diabetes, when the small blood vessels of the kidney are getting affected, the size of the pore in the sieve goes up, then you will start leaking more and more protein. When there is more and more protein leakage through the urine will become frothy, the patient will develop all the complications of kidney disease. One important fact, many of the people having type 2 diabetes mellitus, at the time of diagnosis itself, they will have a kidney disease. So how to test for the kidney disease? There is a test by name microalbuminuria. You should always tell each and every person having diabetes, go and get one microalbuminuria done. Usually, the level of microalbuminuria for all of us should be less than 30. If it is between 30 to 300, it is called moderately increased albuminuria. If it is more than 300, it is called severely increased albuminuria. So what do you do when you come across a person having 30 to 300? Usually with the help of the diet, lifestyle and medications, immediately you should control the diabetes so that the kidney disease is not progressing. But if the value is more than 300, apart from controlling the diabetes with diet, lifestyle, and medications, we should start few medications to protect the kidney, like the AC inhibitors, like the ARBs, which are usually given for hypertension. And if you go back to the first module, we have discussed there are two important drugs like GLP-1 receptor agonists, which are injectable agents, and SGLT2 inhibitors, which are oral drugs, which can even protect the kidney. So diabetic kidney disease again is one more dreadful complication. You should check for the amount of protein leak. If there is a protein leak, modify the diet, bring down the sugars. If the protein leak is severe, you can start few medications to protect the kidney. So always tell the patient at least once in 3 to 6 months, they should always get their protein tested. And the same thing like eye disease, uncontrolled diabetes, smoking, hypertension, dyslipidemia, all these things can cause diabetic kidney disease. So if they're able to control the sugar now at the age of 30, 40, and if things are fine, post-retirement, they will have a happy life. If they're not controlling the sugar at the age of 35, 40, they continue to have high sugars, nothing is going to happen kidney at this point of time. But the moment they retire at the age of 65 to 70, completely the kidneys will be gone and they have to undergo dialysis. So the end stage is end stage renal disease, where either you need to replace the kidney or you need to start them on dialysis. So this is the importance of diabetic kidney disease. The patients who are undergoing dialysis or who have approached stage 4 or stage 5 kidney disease, there you will modify the protein. In stage 4, there will be protein restriction. We will give them low protein diet, and the a particular patient undergoing dialysis, we usually give a high protein diet. Other than that, for general population having moderately increased albuminuria, there is no need to cut the protein. Next slide. Next slide. This is how just go back to the previous slide. This is how initially they will not have a protein leak, that is normoalbuminuria. Then it will go to microalbuminuria. Then it will go to macroalbuminuria. If the macroalbuminuria is not treated properly, they can have chronic renal failure. But if you look at the time zone, it usually progresses over a period of 10 to 15 years. So many of the patients neglect this particular part. Even though they get the diabetes by 40, they don't keep the sugars under control. By the age of 55, 60, they will start having kidney disease. When you have kidney disease, it's a dreadful condition. You cannot eat anything, you cannot drink anything, you cannot even take a painkiller. It's such a dreadful condition. Everything you need to check and take. So that is a problem with kidney disease. It is a highly morbid condition. Next slide. Next slide. Next slide. Yeah, next slide. Next slide. Next slide. Next slide. You can go to the next complication. I think we have cardiovascular disease. Yeah. So I did not include the neuropathy part here because neuropathy will be dealt along with foot care in the last part. So we have completed acute complications, hypoglycemia, low sugar, HHS, and diabetic ketoacidosis, high sugar. And in chronic complications, we finished diabetic kidney disease and diabetic eye disease, that is retinopathy. Coming to the cardiovascular complications, there is a macrovascular complication. Mainly, we have the block in the heart, or the block in the brain, or the block in the lower limbs. If there is a block in the heart, it is called coronary artery disease, which is nothing but heart attack or myocardial infarction. Block in the brain is called stroke. And when you have a block in the lower blood vessels, you can have symptoms like claudication. So diabetes can cause any one of these things. Diabetes is the most common reason behind the heart disease throughout the world. And heart disease is the most common reason behind death throughout the world. So indirectly, diabetes can cause death. So whenever you have diabetes, always you should keep the sugars under control, or else you can develop heart attack at any point of time. Next slide. Can we have the next slide? So how to prevent this heart attack? Always keep the sugars under control. And if you have high cholesterol, take statins. If you have high BP, take medications properly for the high blood pressure. If you are on the overweight or obese side, cut down the weight, modify your lifestyle, cut down on the stress, and always better refer whether the patient is having heart disease or not. Even though the patient's cholesterol is under control, even though the patient's body weight is normal, even though the patient's sugars are under control, refer the patient to a cardiologist from time to time. At least once in a year, many of these patients should visit a cardiologist for a regular checkup. Yeah, next slide. Just skip all these slides. There is nothing much to be discussed regarding heart disease now. We'll go back to the neuropathy part. Yeah, neuropathy, in the same way the eyes and the kidneys are affected, the nerves can also be affected. Initially, what happens? You will have symptoms and signs like tingling and paresthesia or burning sensation in the feet as well as in the hands. But over the due course of time, the patient will start having numbness. They will start having muscle weakness. They will start having muscle loss. In general, diabetic neuropathy is the most commonly appreciated complication of diabetes mellitus. If you take a poll, counsel 100 patients having diabetes, if you ask them what is the most common complaint, many of them will say, I'm having burning sensation in my feet, I'm having tingling in my hands, I'm having weakness to get up, I cannot squat, I cannot sit down cross-legged. This is the most common symptomatic complication of diabetes mellitus. It is as common as diabetic kidney disease and diabetic eye disease. But the problem with diabetic kidney disease, eye disease, the symptoms are not well appreciated by the patients. Patient might be having a frothy urine. He will be thinking, "Well, something happened yesterday. Did not drink fluid properly." There can be change, frequent change in the vision. Patient will keep on changing spectacles. He will be thinking, okay, I became old, that is the reason I need to change the specs, or the spectacle shop fellow did not give a proper specs. But when it comes to neuropathy, they will clearly tell the doctor, yesterday night I did not sleep, my feet are burning badly. So it is one of the most commonly presented complication. Always remember, when you come across a person having diabetes, you should advise them proper feet or foot care. First thing, they should always examine their feet once in a week or once in a few days with a handheld mirror. Feet are the most neglected parts when compared to other organs when it comes to diabetes. You should tell them your foot should look as good as your face. Never neglect your foot. Take a handheld mirror, examine the feet, because you cannot examine your own foot. In diabetes, invariably, even though the sugars are under control, they'll start losing the touch sensation. So they might have climbed on a small stone or a pebble or a glass piece, which might have entered inside and which will cause an ulcer. Second thing, they should never walk barefoot. Even inside the house, they should be wearing footwear. If they visit a holy place like a temple, church, or mosque, they should always wear socks inside the holy place. Third thing, they should always apply something to the feet. Let it be coconut or a moisturizer 2 times in a day, morning after taking bath, night before going to bed. Bottom of the foot, top of the foot, up to the knee. And if they start developing symptoms of neuropathy, you can treat them. The treatment being, you can give drugs for the neuropathy, then you should always bring down the sugars. And coming to the footwear, there are specialized footwear with diabetes called the microcellular rubber MCR, which are neither too soft nor too hard. You should ask all the patients to use that particular footwear. Can we have the next slide? I think we can skip all these things. You can go to the foot part. Yes, you can stop here. These are the various presentations of diabetic foot. They will have cons, they will have callosities, they will have a loss of arch of the foot and all these things. So it is always better and very, very important to take care of one's own foot. So diabetic foot is the most common cause of non-traumatic lower limb amputation throughout the world. At least 5 out of 10 patients will have some or the other problem when compared to the feet. You should always examine their foot. It is mandatory when the patient visits you. Not only you should examine their eyes and heart, you should always ask them to lift the foot, examine the feet, whether they're dry, whether they're having any injury, and observe for their nails, observe for any interdigital between the toes, any fungal infection. You should always counsel them regarding proper foot care. Many of them don't take care of their feet properly. You should keep on telling them, apply something to their feet and take care of the foot. Next slide. Next slide. I think you can skip many of these slides. So to summarize, diabetes complications, number one, you have acute complications in the form of hypoglycemia and hyperglycemia, that is DK and HHS. And chronic complications, you have microvascular and macrovascular. Microvascular being diabetic retinopathy eye disease, diabetic neuropathy, foot disease, nerve disease, and diabetic nephropathy, kidney disease. And foot has a special importance. It is the most neglected part. You should teach them regarding the proper foot care. And we have macrovascular disease in the form of heart disease, cardiovascular, stroke that is affecting the blood vessels in the brain, and peripheral vascular disease. Can we have a discussion on the COVID? You can have a last few slides will be on COVID. Yeah. So coronavirus, all of you know, COVID-19 pandemic has taken 2020 is practically gone because of COVID-19. It is affecting each and every person, belonging to each and every walk of life. And India officially is ranked number 2. Unofficially, India has overtaken US long back. That is a different story altogether. What is the importance of COVID-19 and diabetes? COVID-19 is like any other viral respiratory infection. So any person having diabetes has an equal chance of developing COVID-19 like a person not having diabetes. But the problem is not with COVID-19, problem is with uncontrolled diabetes. Can we have the next slide? So these are the various symptoms of COVID-19. The patient can have fever, cough, tiredness. They can even have altered bowel habits in the form of loose stools or vomitings. They can even have the loss of smell and loss of taste. They can have weakness. So it doesn't mean any cold is COVID. And at the same time, you should not neglect to have any of these symptoms, especially when you have risk factors like diabetes. Next slide. So why is diabetes important during COVID-19 pandemic? Many of the patients having diabetes are at risk for not recovering from COVID-19, not at risk for developing COVID-19. The risk is same between a non-diabetic person and diabetic person. But the problem is when you have diabetes and when you're obese, when you have hypertension, when you have heart disease, the recovery from COVID becomes very, very problematic. The mortality rates are higher in patients or people having uncontrolled diabetes. If the diabetes is under control, you're as good as any other person not having diabetes. Next slide. So in a recent meta-analysis that was done in 1,576 COVID-19 patients, you can see the presence of comorbidities. 21% of them had hypertension, 10% of them had diabetes, and approximately 8.5% of them had heart disease, and only 1.5% of them had respiratory systematic disease. So diabetes along with hypertension and cardiovascular disease remains one of the most common and prevalent comorbidities in the presence of COVID-19. Next slide. Then this was one more data published from China, which was the mother of COVID-19, where the source of COVID-19 was present. You can see the graph clearly. Severe COVID-19, non-severe COVID-19. The blue color is a non-severe COVID-19, where they had mild to moderate symptoms. Green color is a severe COVID-19 warranting ICU admission. And in the severe COVID-19, if you look at the number of patients or percentage of patients having diabetes, it was same across different populations. So diabetes remains one of the major comorbid conditions that is present in severe COVID-19 patients. 17.6, 16.2, 22%, 19%, 14% of the patients with severe COVID-19 symptoms had diabetes. Next slide. So what happens in COVID-19? The death is not mainly because of viremia. The death is because of a condition by name cytokine storm. So the COVID-19 virus goes and sit practically in each and every organ in the body. Let it be lungs, let it be the brain, let it be the heart, let it be the kidneys. So it produces an inflammatory reaction inside the body called cytokine storm. This is the one which is killing. And on the top of that, when you have uncontrolled sugars, the cytokine storm effect is increased threefold or fourfold. And one more important thing, even though the sugars are under control, if a particular person is developing COVID-19 and if the disease is very much severe and if you're admitting the patient, obviously the patient will be started on steroids and the sugars will become haywire. So having diabetes, having hypertension, having heart disease, you're at risk of developing COVID-19 complications and the recovery becomes very, very, very bad. And one more important point, next slide. This is one more study that was done in the same Hubei province where the COVID-19 originated. 962 or 52 patients were studied. Finally, they were able to study 500 patients. 250 of them had well-controlled diabetes and 250 of them had uncontrolled diabetes. And if you look at the all-cause mortality rate, the mortality or acute kidney injury, acute heart injury, or acute respiratory distress syndrome was severe in patients having uncontrolled diabetes. Next slide. So these are the recommendations which we give outpatients when any patient having diabetes, let it be controlled or uncontrolled, presenting with mild to moderate symptoms of COVID-19. We treat the same way as without COVID-19, but the sugar should settle immediately. Second thing, when the patient is getting admitted with COVID-19 and when the patient is having diabetes, insulin remains the mainstay of treatment. Many of the oral drugs will be stopped temporarily and the patient will be able to switch it on to insulin, let it be the basal or basal bolus. And last thing which I wanted to mention here is post-COVID-19. We should not relax. Let us say a person got COVID-19, he was home quarantined for 14 days and test was negative, he became happy. No, should not become happy. There is a chance of reinfection always. Till date, we have documented officially 3 cases by ICMR which have shown signs of reinfection and the reinfection was positive. Second thing, of late, we started seeing post-COVID-19 sequelae. After 2 months of COVID-19, 3 months of COVID-19, many of them started having complications. Let it be psychosis, let it be dementia, let it be decreased lung functioning capacity, let it be body ache, let it be permanent loss of smell. So COVID-19 is a very, very dreadful condition. We should not take it lightly. We should always continue the measures of sanitation, social distancing, and always wearing the mask. Never relax. There is still time left. COVID-19 is not yet over in India, and Bangalore, as of now, is the worst affected city in the world. Cases are going up like anything. You can venture out, you can go out, but always do all these precautions. We call it as SMS: sanitation, mask, social distancing. Never ever leave these principles. You have parents at home, you have siblings at home, you have others to take care of. You should not transmit the disease to them. Be careful. And once you develop COVID-19, you may recover, but you will have the sequelae. Thank you very much. I think it was a very prolonged session. Any doubts?
Sir, can I ask one thing? That is,
Yes, ma'am.
the vaccine, because you are a medical doctor, we are asking this question. I mean, they are saying the vaccine is coming in November, December. Some are saying it will be available only in mid of April. What is your take on this, sir?
The problem is government is not trying. There are only two governments which have failed to contain COVID-19. One is Indian government, the other one is US government. They're not actually telling the facts to the public. Right from day they told August 15th, on the day of independence, vaccine will come out. First thing you should remember, it is a viral infection. There are very few viral infections which can be prevented with vaccination. Let it be hepatitis B, or let it be rabies, or let it be very few handy. How many of you have taken vaccine for a swine flu? How many of you have taken a vaccine for H1N1? Literally speaking, many of us did not take a vaccine for H1N1 or swine flu. They were also more problematic. The problem with vaccine, we don't know whether this vaccine will provide us an immunity or not, whether this vaccine will work or not. That is first point. Second, there are only two vaccines in the world. One is developed by the Oxford group, the other one being developed by the Chinese group, which are in the last stages of development. They have almost finished their phase 3 and phase 4 trials. They are pending approval by the various governing bodies like FDA. None of the other vaccines, let it be the Sputnik vaccine or the BioVax or various other vaccines developed in India, did not get approval. They did not even finish their phase 1 and phase 2. So the reality, even these two vaccines, Oxford and Chinese vaccines, are being cleared by the governing bodies. They may or may not be effective, and they will never come to India before April 2021. There are 8 different countries which have already taken lot and lot of advanced booking of these vaccines. Probably in November, Oxford vaccine might come out, might, MIGHT, we're not sure. Even if it is coming out, many of the countries have already purchased this vaccine. India is lagging behind. Remember, Indians will never have the vaccine till April 2021. By chance, if something happens, we might get vaccine after 2021. But by this time, by July, COVID is going to settle. So don't believe that vaccine is going to come tomorrow, vaccine is going to come day after tomorrow, and vaccine is going to protect. Vaccine is not going to protect us. There is no proof to say that vaccine gives an immunity. I'm talking about COVID.
No, you are saying that July it will settle down. What do you mean by that?
July, actually, we expected a particular thing that partially it is happening in India. We expected India, it will reach its peak in the month of September last week, and by October it will start sloping down, and by maybe around Dasra, Diwali, it will settle. That's what is happening in many of the parts of India. As you take away Delhi, you take away Maharashtra, you take away Karnataka, but remaining states and remaining cities, what is happening? There is a downward slope. Yesterday, there were approximately 50 to 55,000 positive cases that happened after so many days. Before September, we were having 50,000 cases. It went up to 70,000, went up to 90,000, went up to 1 lakh in September. Now, again, it started coming down to 50,000. By Dasara, Diwali, it will remain at 30, 40,000. And by Pongal, it will become 10,000, 20,000. By July, the disease might die off. That's what we're expecting, natural course, provided we don't have a second peak like Europe. Europe is having a second peak. There are a lot of cases coming up in Europe. If we have a second peak, then we will have second wave. I'm telling you, we have a second wave, then we'll have a second peak as well. So as of now, looking at the trends, it might settle down on its own by July 2021. At least till January 2021, we should be careful.
Okay. Thank you, sir.
Any other doubts?
Sir, I have a question. What
Ma'am.
is when you have Somogi effect, that is your blood sugar goes down in the midnight, no, between
Yes.
2 a.m. to 3 a.m. and it will spike in the morning. So
Yes.
it is a complication of hyperglycemia.
Hypo, nocturnal hypo. At around 3 a.m., the sugar has become low. That is the reason the fasting has become high.
Okay. So at that time, will you reduce the dose of insulin for the night?
Exactly. Night dose of insulin should be reduced, and the patient should be advised to have a bedtime snack before going to bed so that there will not be any nocturnal hypoglycemia.
Okay. In that way, how is Somogi different from Dawn?
Dawn is an exaggerated physiological response. Leave about Somagai and all these things. Each and every one of us, remember one thing, in the Sanskrit literature, they say Brahma Muhurtam. Why? Because early in the morning, many of the hormones will go up in the body. Let it be growth hormone, let it be cortisol, let it be glucagon. Naturally, these hormones go up in the body. That is the reason cortisol is tested at 8 a.m. You have an 8 a.m. cortisol test available. So in dawn, what is happening? The physiological response, there is a physiological increase in glucagon is exaggerated. So there is an
Oh,
exaggerated response. So the sugars will go up. But
oh,
whereas in Somogai, it is a response to low sugar.
oh,
In dawn, there is no low sugar in the morning.
correct.
The response is just the normal response is exaggerated. That's it.
Okay. Thank you, sir.
Any other doubt?
Girls, you can unmute and ask questions. No need to type in the chat. You can just ask directly. Only few participants are there here.
Today they must have got a full dose of complications. Then
It was actually very
very
extensive. It
heavy.
cannot, yeah, it is. It cannot be covered
Very
in a single
informative.
session. That is
Yes,
the
yes.
Very informative.
Uh, because this, no, it has to be at least one complication, 1 hour you will take.
yeah.
So many complications. I think they have to, first time they are all hearing. So it will take
Yes, yes.
time for them to understand and then no, come back.
I think many of them are. I don't know how many of them are there and they're present or not.
Uh,
Around 45 are there, sir.
Yeah, 45 I can see, and I might be thinking, what is this
they
fellow?
have to be present.
Coming after class also. So
Yeah. Anyway, if you want, we'll have a brief session at a later point of time. Let them. The slides are anyway available with you. You can circulate the slides among them, and let them go through the slides. If they want a brief session, we can have a discussion at a later point of time, so that they can pen down their doubts, and we can discuss. You can mail the doubts to me in advance, so that we can just take care of some 10 to 15
You
doubts,
can
and we can.
share your mail ID with them.
Sure, 100%. You can share my mail ID with them.
Okay. Yes.
Good. Anything else, or shall we close?
your mail ID, no? So
Yeah,
that
the same mail ID which I've been using to send the mail to you. You
okay.
can circulate the same mail ID to them.
Okay.
Okay, sir. So,
Vali
Ah.
ma'am, can we take a photo, ma'am, with students
Yes.
who are
Yes.
Mary
Yes.
ma'am, come on the screen.
I am
Yeah,
not.
Azra is telling it was very informative, sir. Thank you.
Yeah. I've seen the message.
Asra,
Thank you very much. Thank you very
unmute
much.
and speak, girls. Today, no, we have given the option. You can unmute and speak.
You should have told me before beforehand regarding the photo. I could have shaved well, and
No problem. This is COVID season.
I'm looking like a COVID-19 patient.
COVID season, beard and hair is very important.
Yeah.
Sir, good evening, sir.
Good evening.
Yeah, Komal, you can, show your face.
Yes,
What
ma'am.
is the state of
Switch on your cameras, girls.
Switch on your camera. Your photos.
Take a photograph.
Ma'am, can you hear me?
Yes, we can hear you.
So I had a question, sir.
Yeah, tell me.
Sir, do the diabetic patients have a special diet to be followed during this pandemic if they are affected by COVID?
Nothing like a particular diet for COVID-19 diabetes. The regular diet which do they follow, they can be on the same diet. You can add up something like an immunity booster. You can add few things like fruits. You can add something like a dry fruit, something like almond, cashew nut, which can naturally boost up their immunity. Apart from that, nothing in particular specific for COVID-19 and diabetes.
Okay, so there won't be any restriction in their diet.
Restriction, the regular diabetic diet, they should continue. That's it.
Yes, sir. Along with the regular one.
If they're hospitalized acutely for COVID-19 and let us say the potassium levels have gone up or something else happened, there the hospital, during the hospitalization, we place some restrictions. But apart from that, when they're home quarantine, when they have mild to moderate symptoms, they can continue the regular diet that they do for the diabetes treatment.
Sir, actually, one question is there. Shifali, you want to ask directly?
Yes,
Shifali, you can ask, sir. Is there.
Put on your
yes.
camera.
Switch on your camera.
Okay, ma'am.
Vedashri, DeCosta, Kamakshi, Rashmi, all switch on your camera.
You can ask Shifali.
Yes, ma'am. Good evening, sir.
Good
I
evening.
had a question. The question was, is giving a combination of cereal like rice and ragi or chapati, like wheat and rice, like that, better, or like does a whole like cereal like rice or ragi separately do the same job, like calorie wise?
It's a good question. Actually, for the lunch, many of the Karnataka, I mean, one of the Kannadigas prefer eating the ragi ball or the ragi mudde. So if they want to have ragi mudde, there is no point in continuing chapati or rice along with the ragi mudde. They can either have one of these. Let it be chapati, let it be the rice, let it be the multigrain, let it be the cereal or ragi mudde. Any one is given for lunch or let it be the dinner as well. So we never go with a combination. Either of these.
Okay, sir. And also, like now the GI of ragi has become so, I don't know, controversial, if I can say. So,
Yes,
what's
it's me.
your take on that, sir?
See, the problem here is we have to play safe between the science and the logic. Science says that new papers and new theories and new evidence states that Ragi is not good. GF Ragi is very high. That's what they're trying to postulate. But if you look at many of the Kannadigas, many of the people from interior Karnataka, Dharwad, or wherever you take, they survive on Ragi. All of a sudden, if you ask a person not to eat Ragi Mudda, it doesn't look good. So the logic is to continue Ragi. So you should play safe in between both and always remember the food which is easily digested. If you take Ragi, you have a Ragi Mudda, you have a Ragi Dosa, you have a Ragi Malt. Malt is easily digested. Mudda is difficult to digest. In between, you have the ragi dosa. You can tell them, have ragi mudda instead of ragi malt or ragi dosa. That's how you have to play. That's it. Simple. Until unless we come across this controversy.
Sir, what about sugar in the fruits? Fruit sugar?
Sugar, many of the fruits can be taken safely. That is the reason, because all these fruits have fructose. We ask the patient or we ask the person to have the fruits between breakfast and lunch as a mid morning snack. So because the fruits will give fiber, fruits will give minerals and vitamins, and the sugars may not shoot up. But if they have fruit in the night or fruit in the evening, the sugars will definitely go up. So one serving per day, the serving size should be equal to one normal or one small sized apple.
Okay. High fiber foods can be taken.
Sir, the one with Goa and all, not very sweet, no?
No, like except for mango and banana, we can't restrict them. Some say that chiku should be avoided. Some say pineapple should be avoided. Some say guava should be avoided. But we usually tell them not to eat, not to indulge in eating mango and banana. They jackfruit as well. They ask us a rebate for that eleki banana. Eleki banana is small. Can I have? Even eleki banana should be avoided. Other fruits, kiwi, avocado, orange, apple, papaya can be safely taken.
Okay, sir.
So I have a question. You said if you have a hypoglycemic episode before lunch, you still give them glucose and then send the lunch. But
Yes, immediately.
But when we were at MV Hospital for Diabetes under Vishwanathan, what he used to tell us is don't wait for lunchtime, just send them the lunch directly
That's what
without
when they
giving
have
glucose.
no. The glucose is very, very mandatory. Now the guidelines have completely changed.
Oh,
Anytime the patient is having hypoglycemia, whether it be before lunch, let us say the patient is having first bite of the meal, is about to take the lunch.
ah,
Suddenly he had low sugar. First glucose followed by lunch, because lunch or anything will take minimum 30 minutes to correct the low sugar.
okay,
Whereas glucose will immediately correct the low sugar.
okay.
Any other doubts?
Girls?
Any
Any
doubt?
doubts?
I think it has to register in
Sir?
their head.
Yeah.
Vedashri, you don't have anything to ask?
Sir, about the fist rule, sir.
Ah,
So like my hand is quite bigger than my sister's. So
good, good.
the quantity will there will be a difference in the quantities, no, sir.
Yeah, good question. Ideally, your hand should suit you. Your sister's hand should suit her. So the
Oh,
patient's hand will suit him or her. That's it. Simple.
our own hands.
Our own hands. But you can't tell
Okay,
the
sir.
patient to have this much showing your own hand or your sister's hand or my hand. My hand is also big.
Okay, sir. Thank you.
Good. Good question anyway. Any other?
I think, ma'am. Yes. We'll
So
take it.
now they have included microalbuminuria test in the routine test now, or we have to
Simple
ask for
100.
it?
Yeah, it is included in routine test in many of the diabetes specialty centers. It is mandated to get the microalbumin done.
Okay.
Even in pregnancy, they do know, sir, this albumin.
Pregnancy is actually, we don't usually do microalbumin because invariably it will be high. Even if it is high, we can't do anything because you
Okay.
can't give statins, you can't restrict the protein diet in the protein. So pregnancy, even though they have microalbumin, we wait. We don't do anything during pregnancy.
Only during GDM, they will have this microalbumin high, right?
Yes, yes, correct.
Sir, when it will be confirmed in GDM, sugar hyperglycemia? Like the
Usually the protocol says 24 to 26 weeks they need to get tested. But nowadays, every pregnant woman, irrespective of pre-pregnancy weight, irrespective of family history, should get the test done immediately after conception.
Oh.
Ideal test is OGTT, not HbA1c. Give
I
75 grams.
have a question. What is the difference between OGTT and oral challenge test?
Both are
OGC.
same. OCT and OGTT are, we are challenging the body with glucose. Oral glucose tolerance test and oral challenge test are same. The only difference is we have different types of OGTT. Oral challenge test in India, they have created a special criteria where only 2 samples are taken because pregnancy is a stage of discomfort. You can't ask the mother to wait for 3 hours and take 3 samples.
Okay.
So we have advised 2 steps, that is fasting and 1 hour. That is the IA-DPSG criteria on the DIPSI criteria devised by Dr. Seshay from Chennai. So in OGTT, we usually do 3 samples, 5 samples, sometimes 7 samples. It is called extended OGTT. In oral challenge test, either 3 or 2.
But we start with fasting.
We start with fasting invariably. 0 is fasting. After that, you give either 75 grams in India. In US, they have a different criteria by name Carpenter and Custon, where they give 100 grams of glucose.
Okay.
We will.
Any other doubt?
Any doubts, girls? So maximum doubts are cleared, those who had doubts. So thank you very much, Dr. Chaitanya. And we were teachers, we were having a discussion. I think this should not be like 3 hours. I think it should be like a 30-hour program. We should have one session certificate course or this. So we will get back to you once we think that diabetes, it is a ocean, I can say. We have to, every day new things are coming in, as drug or diet, MNT, whatever it is, new. Every year we learn new things. So I think the updation is required for the teachers like us. Like faculty development program, we must have diabetic development program now. So we will come back to you. So you can give us some guidance to take up this diabetic course.
Definitely. We'll plan that. I'll happy to take over that and happy to take an extended session, provided the audience are not getting bored. And one last question is there.
Interested audience will come there. Those who want to really learn more about it,
Sure.
Yes.
Definitely.
Yes.
Someone by name Arwa Mushtaq was asking, the patient is going through a hunger episode and has polyuria. what can be done before the situation becomes worse. If you're asked about diabetes, hunger episode and polyuria means high blood sugar. So immediately you need to correct the high blood sugar so that the conditions will not getting worsened.
Vedashri wanted to ask something.
A course on
Course and diabetes
Mute and ask.
will be very interesting.
yes, yes.
So what, like, could you like talk a little about PCOS and diabetes, like the connection?
PCOS is like a prelude to diabetes. It can cause diabetes in the future, whether it is treated or not. So it itself is a risk factor for developing diabetes in the adulthood. So PCOS is like a pre-diabetic state present during the menarche, during the adulthood, when there is a problem with the ovulation. If treated properly, and many of these PCOS women or girls invariably will have weight gain, will have obesity, will have insulin resistance. So it is a complex which can result in diabetes in the future. They are at risk for developing diabetes. You should treat them properly. They should lose weight, and you should advise them regular checkup. Let it be HbA1c or the other things.
They are also treated
Treatment.
with metformin, no, sir?
Yes, the treatment for PCOS is metformin, which is again a drug given for diabetes.
So we have insulin assays.
Yeah, we do have insulin assays as well.
Okay.
Insulin assays in the sense, are you? I mean, you mean to say regarding the test?
Yes. To
Yeah,
see how much of insulin we are producing.
Just a minute now. So we have a test called C-peptide, which indirectly tells us how much of insulin is present inside the body, because insulin is very difficult to measure. It is very, very short living and short acting.
Oh, okay.
So indirectly measure insulin. Every insulin molecule is again produced along with C-peptide. C-peptide is connecting peptide. Insulin has A chain and B chain. So 1 molar of C-peptide is equal to 1 molar of insulin. So if you measure C-peptide, you can indirectly measure insulin.
There is a question, sir.
For those who get COVID-related diabetes, does it remain permanent or does it go to normal sugar levels? Very good question. I have twins who are my friends, Vinay Shankar and Vidya Shankar, who studied with me in school. So both of them developed diabetes during COVID-19. They were admitted in Care Hospital, Hyderabad, and they were given steroids. And after the steroid therapy, suddenly they developed diabetes. And I have treated them with insulin, with oral drugs. As of now, they have responded very well and they became normal, and they're now continuing oral drugs, but we have to wait and see whether they will become completely normal. Usually steroid induced diabetes will become normal at a later point of time. But in the setting of COVID-19, we have to wait and see whether that is a permanent diabetes or it is a transient or a temporary one. We are not sure about that as of now. If a lady with PCOS is pregnant, does that put her at higher risk? Yes, definitely. It's a double risk of developing gestational diabetes. Any other doubt?
Okay, so far.
Thank you for the opportunity.
Doubts were,
First, put on your camera. Only take a photograph.
yeah.
Girls, come on screen. I can see Kamakshi, Vedashri. Thanks, girls. Come.
Azra,
Asra.
Shubhati, Sakshi, Shubhada, Samruddhi. We have to call them.